Good morning. I'm Mark McClellan. I'm the director of the Duke Margolis Center for Health Policy, and I'd like to thank all of you for participating in this morning's webinar to discuss accelerating delivery system and payment reform in the safety net. For making this possible, I'd like to thank our expert partners. You're going to hear from many of them today. Our team at Duke Margolis, Jonathan Gonzalez-Smith, Sherry Wang, and Frank McStay, for helping to put this together. A special thanks to Arnold Ventures and the Commonwealth Fund for supporting this webinar and making the related research and policy analysis possible. And especially all of you for joining. As you know, safety net organizations play a vital role in providing care that millions of low-income and underserved Americans fundamentally depend on. They are a critical part of our healthcare infrastructure, yet they face special challenges in providing longitudinal, coordinated care for these high-need populations. They've been frontline providers throughout the COVID-19 pandemic, stretching our resources further to serve many of the hardest hit and under-resourced populations. But despite the efforts to support these organizations, there have been many challenges in their existing payment models and traditional policies that create constraints for safety net providers to deliver the best care for their beneficiaries. Some of these important constraints are financial, many of them related to how resources are provided, often in a siloed way, and an increasingly widely adopted approach to address these challenges in the safety net is the shift to value-based care and payment models. Value-based payment can help create and sustain a delivery system that provides more coordinated, longitudinal care to meet each patient's needs. These care models can help providers who are accountable for the health and well-being of their patients deliver not just specific medical services, traditional medical services, but bring the right services to the right patients to help them stay well and improve their well-being. Value-based payment and accountable care seem like approaches that would be particularly important for underserved populations with complex health-related social needs and medical needs to help safety net providers bring together the care that addresses those needs: advanced primary care, behavioral health, needed social and community services, coordinated specialty care to avoid costly complications. This coordinated approach can make safety net resources go farther to increase the capacity of safety net systems to treat those who are less well resourced and who have greater needs. But safety net providers have historically not had equal opportunities to participate in value-based care reforms. To address this issue, we're interested in identifying policy opportunities to accelerate safety net provider participation in new ways of paying for care and support the earnest work being done across the country to improve outcomes and equity. As part of that, we released an article this morning in Health Affairs Forefront on leveraging payment and delivery transformation strategies to drive coordinated longitudinal care and improve health outcomes in the safety net. We're going to link that in the chat for your reference. Building on this work, we're collaborating with a group of experts and stakeholders to release a further report with more detailed recommendations and examples of steps that policymakers, payers, safety net providers can take to improve longitudinal coordinated care that meets the needs of people in the safety net. There's not a one-size-fits-all solution. There's certainly not an easy magic bullet, but there are ways to help develop supports to assist safety net organizations that are ready and able to participate in value-based payment models, the tools, transitional assistance, and guidance they need to make it easier to take steps in the short term, but also to get on a path for more substantial long-term reforms. And this fits with a high priority for the Centers for Medicare and Medicaid Services and a growing number of states to provide access to coordinated longitudinal care. CMS has set a goal of doing that for all Medicare beneficiaries and the vast majority of Medicaid beneficiaries by 2030, with a big acceleration in progress slated to start this year. So for today's meeting, we're going to focus on feasible steps that providers, payers, and policymakers can take to enable broader safety net participation in value-based accountable care models. We're going to have 3 sessions. First, we're going to start with a brief overview of our findings. You're going to have to hear from me for a little bit longer for that, our recommendations for safety net payment and care reform. Then we're going to hear in more detail from some safety net providers who are making the shift into more comprehensive accountable care models, as well as leaders in the field on strategies and policy considerations for successfully engaging and supporting safety net providers in accountable care. Finally, our last panel will feature policy leaders from federal and state agencies, including HRSA, CMS components, including CMCS, to discuss policy levers and opportunities that they're using to help safety net providers make these changes, to meet them where they are, and increase the array of supports available to move to better aligned financial models to advance accountable care in the safety net. We are recording this meeting. We're going to post it to our website shortly, and you can submit a question using the Zoom chat function that we'll try to get to in our discussions. Now, I'd like to turn to Corinne for some opening comments.
Thank you, Mark, and thank you everyone for joining us today. I'm Corinne Lewis, Program Officer for Delivery System Reform at the Commonwealth Fund, which is a national foundation committed to advancing a high-performing health system, particularly for low-income people, people of color, and the uninsured. At the Commonwealth Fund, we've been supporting work to scale and improve value-based payment models, which we believe, when well-designed, can be vehicles to improve quality, make care more affordable, and critically to advance health equity, all while giving providers greater flexibility to deliver comprehensive care. And as Mark mentioned, despite the promise these models hold, we've found that safety net providers, and therefore the communities that they serve, have been largely left behind in this movement towards value-based payment, in large part because they face greater barriers to participating. So we, along with Arnold Ventures, have been partnering with the Duke Margolis team to tackle that very issue and identify policy and payment opportunities, both at the federal and state level, to support safety net providers in engaging in these value-based models. And I just want to thank the entire Duke Margolis team for the excellent work on this project and for pulling together such a great group today. I'm really looking forward to the conversation. Thank you.
Thanks, Corinne, so much for your leadership and support. And I'd now like to turn to Lily Ellis from Arnold Ventures.
Thank you, Mark. It's great to be here today. And thank you, everyone on the call. Really excited to hear your perspectives. My name is Lily Ellis, and I am a director of 2 portfolios at Arnold Ventures. Arnold Ventures is a policy-focused philanthropy, and our healthcare work really focuses on healthcare costs and making healthcare more affordable for patients and families, and also for employers and the government and taxpayers. And my portfolio is really focused on advancing population-based payment models. We feel, just like as Corinne said, these models hold great promise for improving care for all different kinds of patients by giving providers greater flexibility to really tailor the care and resources where they're needed to meet patients' needs. And of course, we're really focused on trying to make sure that all providers and the patients they serve have access to these kinds of models, and are really excited to be partnering with Duke on this important work to advance safety net providers' participation in these kinds of models. So I'll stop there, but I just want to thank you all again for taking the time to participate today. We're really excited about Duke's new piece that came out today, and really appreciate the full Duke's team's hard work on this project.
Thanks so much, Lily. We really appreciate the support. And now to kick off this framing of our presentations today on accelerating delivery system and payment reform and the safety net, I'd like to turn to my good friend, longtime colleague on issues related to accountable care adoption, someone who seems to have an endless tolerance for getting up at 6 or 7 a.m. Pacific time for events and activities with us, my good friend, Mark Smith.
Thanks, Mark. So yeah, for those of us from California, it's dark 30 out here. But I want to thank Mark and thank all of you for being here. I'm going to keep my remarks short. I want to make basically 3 points here. First of all, we toss around these phrases like value-based payment, and I know that's very popular in wonk world, and I'm as guilty of that as anybody. But we need to make sure that payment doesn't become an objective for its own sake. The reason we're talking about payment reform is as an environmental incentive to change the delivery system. Over the last decade or so, there's growing consensus that we want care delivered for ourselves and our families by organizations that are willing and able to take both comprehensive, that is to say, not just one organ and not just physical and not just mental, but comprehensive care and longitudinal care of people. And to the extent that our delivery system is shaped in part by the reimbursement system, the payment system that drives it, our conviction is that changing the way we pay for care is an important prerequisite to changing the way care is delivered. But it's about changing the way care is delivered and not changing payment for its own sake. So every health system component, whether that's a school-based clinic or an inpatient hospital or outpatient specialty care or outpatient primary care, mental health, whatever, ought to be in a circumstance where its actions and its records can be shared by its colleagues and where there can be allocation of resources to take the best comprehensive and longitudinal care of patients. And our conviction is that that's true of patients who are seen in the safety net, as it is true of people who are seen in the commercial system or seniors in our Medicare system. Second, we don't expect that there will be a one-size-fits-all payment system because we don't have a one-size-fits-all healthcare market from one state or one city to another. You'll hear from safety net providers today who exist in a bunch of different kinds of ecologies. And so there'll need to be solutions that are responsive to and respectful of their different circumstances. It also means that in the safety net, not all providers are prepared or willing right now to move forward beyond the kind of traditional and hard-fought volume-based special deals that they've won, whether that's cost-based reimbursement or dish payments or volume basis on visits or whatever that basis is. Not everyone is in a position to move forward, but some are. And so we've got to strike a balance. We've got to thread a needle between, on the one hand, not requiring that everyone who's not prepared to move forward be required to do so, but on the other hand, not having a least common denominator policy set that actually inhibits those who are prepared and able to move forward from doing so. So our objective here is to find a pathway to where we can focus resources in providing incentives and opportunities and support for those safety net organizations that are willing and able to move towards a more comprehensive longitudinal delivery system to do so while not undercutting the hard-fought and necessary volume-based safety net lines of payment that currently exist and predominate for those institutions. Thirdly, we have an opportunity right now to address this in part because of the growing consensus on the importance of equity in healthcare. You cannot talk about equity in healthcare in the United States without talking about supporting and advancing and accelerating the capacity of the institutions that provide the overwhelming portion of care for low-income and underserved people. So it is one thing to talk about highly resourced institutions now being concerned, perhaps more recently, about equity, a good thing. And yet, the vast majority of low-income people are either uninsured or assured by Medicaid or marketplace mechanisms for which the safety net is ill-prepared to deliver the kind of care that we have agreed is the care we want for ourselves and our families. Those are the objectives of this project. We very much appreciate the support of the Commonwealth Fund and the Arnold Foundation, and we appreciate the support of those of you who've been working along with this. And I will now shut up, hand it back over to Mark, and participate in this conversation. We think it's an important one for the future of the country. Thanks, Mark.
Thank you so much, Mark. And now I'm going to spend a few minutes expanding on Mark's remarks about how we've approached these issues in the project and tee up our panels. So as you've heard, people who receive care through safety net providers today have been less likely than other Americans to have access to this accountable value-based care, which again is not about the payments, it's about the coordinated longitudinal services. That's because safety net providers have been in payment systems that have been fee-for-service based, very tight, and also fragmented across a number of different funders. This can lead to care delivery in the safety net that provides unquestionably valuable services, vital services, but the individual silos can complicate efforts for safety net providers to work together to deliver well-coordinated care for the patient's whole journey. Advanced primary care that meets people where they are in the community, that addresses their health-related social needs, behavior and specialty care needs that are integrated as well, all in a way that uses limited resources and the abilities of all the providers involved as efficiently and effectively as possible. With limited funding tied to delivering specific services, it can be difficult to make the upfront investments to build capabilities, partnerships needed to coordinate this full spectrum of care, the services that are most important for each person's well-being. So as part of this broad goal of advancing accountable care, there have been many important recent actions and progress from CMS, HHS, states, and other funders to expand payment reform opportunities and coordinated care for safety net providers to improve multi-stakeholder alignment to support these population health models in the safety net. For example, the CMS Health Equity Agenda explicitly prioritizes increasing safety net participation in payment and delivery reform. CMMI models like ACO REACH in Medicare are providing more resources for harder to reach populations served by safety net providers, including community health centers and participating public hospitals. In Medicaid, the largest single funder for safety net providers, the Centers for Medicaid and CHIP Services has provided more guidance and examples of how to use state plan amendments in lieu of services and other guidance to facilitate safety net providers and their Medicaid plans to implement value-based payment reforms with goals like addressing social drivers of poor health. And a growing number of states are adopting so-called 1115 waivers that lay out more comprehensive long-term paths for payment reforms for safety net providers and their Medicaid plans to undertake value-based reforms and provide more comprehensive care. This includes states like California, Massachusetts, Oregon that have made innovative payment changes in their Medicaid programs, and safety net providers in many other states that have formed accountable entities to enable them to use resources in Medicaid and combine with other funding streams to invest in longitudinal data systems to expand access to needed services like integrated behavioral health to coordinate with specialists. So in our project, as reflected in that overview paper released in Health Affairs Forefront this morning, and as Mark Smith noted, we've sought to identify and highlight promising further opportunities for policymakers, payers, and providers to advance this shift toward whole person accountable care in the safety net. This project is building on the work of many public and private organizations to bring together examples, guidance, other resources that can help interested safety net providers, states, and their federal partners advance the delivery of accountable care and reach a growing part of the populations they serve. And also, we hope through this effort to identify additional feasible steps by federal agencies and others to accelerate progress. We've done this in close collaboration with an executive leadership group composed of experts. I'd like to thank them personally for their contributions throughout the process. This includes Jana Eubank, Executive Director of the Texas Association of Community Health Centers, Elliot Fisher, Professor of Health Policy Medicine and Community and Family Medicine at Dartmouth, Patty Gabel, former CEO of Denver Health, Christina Severin, President and CEO of Community Care Cooperative in Massachusetts, and Mark Smith, who you've already heard from. With their guidance, we've conducted targeted literature reviews, held interviews and convenings with safety net organizations, particularly those that have implemented accountable care reforms and are contemplating further reforms. And this is all highlighted in that Health Affairs Forefront paper with examples and a framework for how value-based accountable care and the safety net can transform patient journeys and enable resources to go further in improving the well-being in this population. So to develop these capabilities, as we describe in the paper, this includes shifting from siloed funding, some more aligned reimbursement streams that can come together at the level of the people these organizations are serving, with the funds explicitly tied increasingly to the goals of accountable care, person level goals, not provider or service specific goals. Safety net providers like FQHCs, behavioral and substance abuse clinics, safety net hospitals can start using these streams to as an accountable entity to better coordinate care and fill priority gaps in services. A comprehensive example of this that you'll hear more about a little bit later is Community Care Cooperative. They're an FQHC-led ACO that successfully brought together community health leaders and their funding streams to pool risk, earn shared savings, and leverage this funding flexibility to deliver better coordinated and more comprehensive patient care. Accelerating progress requires intentional actions from federal and state policymakers and payers, as well as safety net providers. At the federal level, federal payers, including CMCS, CMMI, I mentioned, Center for Medicare, HRSA, and other agencies, have taken steps and can take more to clarify how their distinct funding streams and requirements can contribute to supporting coordinated systems of care. This can include using some directed grant programs to support upfront investments to enable these kinds of care models, like investments in data systems or training and supporting new members of care teams like doulas or community health workers. It can mean working to align quality and accountability measures across these different funding programs to create a simpler path for safety net organizations to leverage funding streams for improving person-centered care. At the state level, states do play a critical role, and there are growing examples, as I mentioned before, of how they've used a variety of Medicaid levers and federal grants within their disposal, such as state plan amendments in lieu of services, state-directed payments, and other federal grant opportunities to support these goals. So the strategy involves creating accountable funding streams, which might consist of time-limited funds like grants that can especially help with upfront investments, as well as longer-term funding streams like Medicaid payments or alternatives to traditional PPS HRSA payments to help safety net providers not only develop, but then sustain the care models and community collaborations needed to deliver accountable care. For providers, this shift from fee-for-service and other service-based payments to accountable funding streams enables key aspects of value-based care in the safety net, including, as we talk about in the paper, more accountability for people, not just services, and the most important services for their particular needs. Coordination, the capability to implement these models across multiple organizations through data sharing infrastructure, through governance that involves people served by the programs and reflects their longitudinal care priorities, through promoting equity, a greater ability to identify and track improvements in equity gaps in the communities they serve. And to that end, our overview paper and our expansions and further work focus on key recommendations for policymakers and payers to facilitate this pathway to accountable whole person care. This includes supporting cross-program alignment across payers and policymakers. It includes facilitating access to accountable funding streams that include the support for upfront investments and ongoing person-focused payment structure. It includes providing guidance and technical assistance to assure states and safety net providers that the transition to value-based payment is something that they can undertake through the technical assistance and examples of to drive needed care transformation. And finally, to create pathways to integrate social and community support to address social needs. And by the way, I'm glad to see an active Q&A and chat already, as Paul Hughes-Cromwick mentioned, and we highlight in our report, there are a number of efforts like federal coordination to support community health hubs to create communities that can truly integrate health-related social services and medical services behind these coordinated safety net care providers. So lots to talk about here. And to get that going, I'd like to turn to Jonathan Gonzalez-Smith to kick off our first panel.
Great. Thank you, Mark. As Mark mentioned, lots to cover. In this panel, we will be discussing opportunities and strategies for providers to participate in accountable care models. We're going to be hearing from exemplar safety net institutions that have adopted or are considering adopting value-based payment models, strategies and barriers for providers to participate and improve care in the safety net, and opportunities for further policy reforms to create pathways for safety net participation in value-based payment models. As both Marks discussed, the safety net is incredibly diverse, made up of a wide range of providers, each with their own unique set of challenges, operating environments, healthcare ecosystems, and local marketplace dynamics. And the panel today really reflects that diversity. You'll be hearing from a variety of perspectives, including those from the community health center perspective, public hospitals, and rural hospitals, but obviously there are a broad number of other provider types that are not included today, and hopefully we capture those in our recommendations forthcoming at the end of March. So I'll briefly introduce these esteemed panelists and then dive right into our conversation. Christina Severin is President and CEO of Community Care Cooperative, one of the nation's leading ACOs in Massachusetts, founded and governed entirely by FQHCs. Since its inception in 2016, Christina has grown C3 into the largest FQHC-owned organization in the country, serving key Medicaid populations in Massachusetts and leveraging best ACO practices to successfully take on risk and provide high-quality care through the collective coordination of C3's FQHCs. Elaine Batchelor is CEO of Martin Luther King Jr. Community Hospital, a California health system that includes a safety net hospital and community population health programs. She has been nationally recognized for her efforts to improve access to quality health care for underserved communities in the South Los Angeles community, and is a member in the National Academy of Medicine, as well as an Irvine Foundation California leader. Jana Eubank is also joining us. She is the Executive Director of the Texas Association of Community Health Centers, a primary care association that supports and advocates for community health centers in Texas. Throughout her career, she has been a steadfast policy advocate for community health centers, working to better position safety net providers to succeed in payment and delivery reform initiatives. She has earned several national and state awards for her advocacy work to support community health centers and patients. And Terry Scogan is also joining us. Terry is the CEO of Titus Regional Medical Center, a rural health system in Northeast Texas. He oversees Titus's work to provide high-quality diagnostic and medical care for rural patients, and has worked to improve rural health disparities in his community. He serves on the American Hospital Association Future of Rural Healthcare Task Force and the Texas Organization of Rural and Community Hospital Boards. So thank you all for joining us today. I request that the panelists go on camera, and we can kick off our discussion. To begin, I might ask each of you in turn to describe what does successful payment transformation look like from your perspective, and what do you think are necessary steps to get there? As Mark Smith noted, we aren't just aiming for payment reform in an end of itself, but as a way to truly and meaningfully transform the delivery of care. And so to kick things off, I might turn to Christina Severin. As an FQHC-led ACO, C3 offers a unique model on participating in value-based contracts. And curious if you could just walk us through why FQHCs saw the need to set up their own ACO and what elements of payment transformation were critical to supporting health centers on this journey.
Great. Thanks, Jonathan, and thanks to you and all of your colleagues at the Duke Margulies Center for having me as our participant in this event today. And congratulations on this morning's publication, Health Affairs. That's a great milestone for your work. So on your question, one of the things, well, I guess the first piece of your question is sort of why did we do what we did? So in 2018, Massachusetts went live with a renewal of its 1115 waiver. And although the waiver had been in place for 20 years, it was the largest restructuring of the Mass Health, which is what it is branded in Massachusetts. Medicaid is branded in Massachusetts, the largest restructuring of the Mass Health program that had happened in 20 years. And specifically what happened is the 1115 program moved from a managed care or MCO program to an accountable care organization or ACO program. And at that time, as you might imagine, there was a lot of sort of industry brokering and scrambling over what this new landscape would look like. And so the health centers, very serendipitously, we kind of ran into each other at a board meeting, at the market, what have you. And we all were sort of having the same concept, which was, geez, the way that things usually happen is that the organizations with less assets, not as strong balance sheets, for example, us, the federally qualified health centers, end up needing to sign on to a larger organization, such as a health system, could be others, but such as a health system, in order to have what had always been perceived as the safe environment to take on new initiatives, such as a new ACO initiative. And we said, well, what if we actually did things differently? What if we could figure out a way to start our own company, come up with our own plan to capitalize the company, get a data infrastructure going, a care management infrastructure going, practice transformation, et cetera, and needed reserves, and have this be a 501c3 health center controlled and governed entity. People thought it was impossible. And the good news is that one thing led to another over a period of time, maybe about 12 months. We got together our capital plan. We grew the interest at health centers, and we were able to go live with this new company and bid and receive a contract from state government to become one of the ACOs in Massachusetts. And today we have about 2/3 of the FQs in the state in our company, and we are the largest Mass Health ACO and the largest FQHC-based ACO in the country, taking both two-sided risk, shared savings, and shared losses. And knock on wood, haven't had to go to shared losses. To get to the second part of your question, sort of what does successful payment transformation look like? When I'm asked that question, before I get into detail, what I say is, remember that video that people show about equity? And it's a bunch of people who are running a race, and they're at the starting line. And they're asked a series of questions, and their answers to the questions put them at a more advantage or less advantage vis-a-vis the starting line. I think that that's completely analogous to the safety net and how we need to be successful in payment reform. Specifically, recognize that not all organizations have an equitable place on the starting line in the journey to value-based care, and therefore put in steps to create an equitable starting line, even knowing that it is appropriate for some steps to be in place for some organizations who have been at a disadvantage in the healthcare ecosystem, while it is not needed for others. And then the second half of your question was sort of, well, okay, well, what might that be? And I think you do a nice job in your paper talking about some of them. And I would echo a lot of that and add others, I think, in no particular order, really, and maybe starting with some things that exist in the ecosystem, either locally in Massachusetts and or nationally. So in Massachusetts and with ACO REACH, we see the emergence of a benchmark or a budget that accounts for more than just the ICD-10 characteristics of a population. There are many different ways to do this. ACO REACH methodology is showing us one way, which is excellent. Massachusetts Medicaid is using another way. They're building up a neighborhood stress score, which takes into effect things like unemployment in the census tract, level of poverty in the census tract, other things like engagement with the Department of Mental Health, Department of Children and Families, an experience of homelessness, major mental illness, and other factors are incorporated in addition to the regular diagnostic, age, sex, what have you, disabled, non-disabled, to really create a more robust and accurate down to the person benchmark. Massachusetts does other things, like rather than having a race to the bottom around your own experience, you are competing against the average market price, which generally speaking, a safety net organization like a health center will do a very good job. Put that in contrast with a rather typical, not one size fits all, but a rather typical risk contract with a managed care plan, which is your own experience and building up your own experience that you need to beat. Your own experience may be one that has already been deflated because you are being paid less than what the rest of that provider network is being paid. Another really important one would be back to the analogy of level playing ground. One really key factor in creating an on-ramp for safety net organizations to advance payment models is access to needed capital. This could come in different forms. It could come in upfront cash investments. For MCOs, it could also come when MCOs are built at capitation rate by state government. They include a risk, so-called risk underwriting margin, or some extra funds in recognition of the risk that MCO is taking on. And I would strongly put forth that if an MCO is contracting with an ACO, and particularly a safety net ACO that is going to be undercapitalized, that a portion of that risk margin be passed to the safety net ACO in an amount that is commensurate with the risk being taken on by the accountable care organization. I could go on and on all day probably on this topic. I'm very passionate about it. I will leave it there.
That is very helpful, a lot to digest there. I think we can pick up from some of the elements that you just noted. In particular, we heard from you and from others throughout this research about the importance of providing upfront capital, some of the flexibilities that payment reform can offer. And so I might turn to my Texas colleagues and to maybe elucidate from their perspective within the unique parameters of operating within Texas, what that might look like and what a successful payment transformation is in the Texas setting. So maybe Terry, I might turn to you as representing the rural hospital perspective. How does that affect your operations, and what do you think is sort of a good operating model to help you deliver the care that can help your communities?
Good morning, and thank you for the opportunity, including us. I've enjoyed the article this morning, but I've also enjoyed some phone calls over the last few months to understand. We appreciate the opportunity to tell the story of rural. We are the last independent hospital left in Northeast Texas. There's 35 counties. I'm 60 miles from the Oklahoma, Arkansas, and Louisiana border. So we're right there in the northeast corner of Texas, and we are independent. And we serve 31,000 people in our county and about 72,000 in the 5 counties that we support. So we've seen 4 hospital closures in the last 7 years within 40 miles of us. And Texas leads the nation in hospital closures. So I see what a hospital closure does to a community. It destroys. I was there in 2014 at midnight when the hospital shut down, and I saw what it did to those people. And I never want that to do that to my home and to our community. So this is personal, but rural has its own challenges. When you talk about value-based, rural in itself, older population, so a lot more Medicare. A lot sicker population. I'm going to live 5 years less than I will in Austin because I choose to live in a rural community. That's the reality. That comes with more comorbidities, more agricultural, more industrial, lack of access to primary care, lack of access to healthy foods. We have a high uninsured population here. We're 33% adult uninsured. We're very diverse, have a very low unemployment rate. However, our capita our dollar income per capita is very low, just above the poverty rate. We have 2,900 employees who work at a meat processing plant in town. So a lot of jobs are just very low paying. So with that comes a 33% uninsured. You just have a lot of those issues from a rural standpoint. When you start talking about how do you do things from a value-based purchasing standpoint, as a rural hospital, it's difficult. I don't have the ability to negotiate contracts. Blue Cross Blue Shield, no disrespect to anybody. They hand me a contract and there's no negotiation. Your commercial payers and your MCOs, I'm one where they would rather deal with your larger health systems where they're working at 40 and 50 hospitals in that contract. So it's very difficult. So anytime you tie value-based purchasing to fee-for-service, we lose. We lose from a Medicaid standpoint on the new states programs, anything that's tied to those payers, MCOs. Texas was successful, I thought, in 2012 when they did the DSRIP program. In our health system, my second day at this hospital, I went to the DSRIP kickoff. And, over those 8 years of that program, we were able to do some great things. We built 2 large primary health centers. We're now seeing 55,000 primary care visits on an annual basis. That started 7 days a week. Only day we close is Christmas because I'm not going to make God mad. So, we have the opportunity. We're open late. We're open weekends. We brought neurology. We're a primary stroke center now. Northeast Texas is 50th for stroke deaths in those 35 counties. But what we're doing in this county is amazing from stroke care because of the DSRIP program. So DSRIP worked, but other programs don't. So we talk about value-based purchasing. Dr. Smith said it earlier, and Christina said it well. There's not a silver bullet. What works in the urban does not work in rural. And what works on the East Coast in rural probably is not going to work on the in Texas in rural as well. I'm going to tell you the West Texas doesn't work the same as East Texas and the challenges. So we've got to figure out a way in value-based purchase to take the commercial payers out of it, take out try and get that money to the health systems that need it. I talk about the challenges we have. Please don't take in that I'm saying we have less care. We're providing unbelievable care. We're a Leapfrog A hospital. We're a Joint Commission accredited hospital. We've been in this community going on 70 years now. We're a primary stroke center. We're a primary heart attack center. We have unbelievable. If you have a stroke and you're on I-30, please, I hope you have it in Titus County, because I promise you, you're going to do better than you will in the Metroplex or in other large cities, because our door to needle time is minutes. We have nation leading stroke care and a cath lab that's 12 seconds away from my emergency department. So, I hope you have a heart attack and stroke close to us and not out in some of the other areas of rural where you don't have that ability. But, those financial and value-based purchasing, is critical for the future. You talk about some of the things we're doing for a successful one. We are joined with the Texas Organization of Rural and Community Hospitals. There's 158 rural hospitals in Texas. 14 of us has joined together to create a clinical integrated network. I'm the only one east of I-35 on the east side of Texas that's part of it. A lot of it's West Texas and Central Texas, but we're starting to come together to see how we can write value-based contracts. The other part is I'm on Epic through a relationship with Ochsner in New Orleans. So I was able to negotiate an EMR that's not a competitor of mine. So I'm able to partner with New Orleans and partner with a software that allows me to track all the outcomes that are so critical. MyChart gives access to the community, social determinants of health, and tracking those. We are part of Ochsner's ACO. I was part of an ACO with Caravan, like many rural hospitals. Had the opportunity with Ochsner to join their ACO that's tied to my EMR, so I can see real-time data on how we're doing. The ACO and CMS, I know it's difficult to do what you're told to do and checking boxes, but if you think about the big 7 that you're scored against, it's population health and it's good care. So, there's a lot of good things that are coming out of that ACO that we're taking into the community. We're not getting paid for it. That's not the things Texas' new 1115 waiver program is looking at. They're looking at the DPPs on other things. It can be so much simpler, but having the opportunity to participate with Ochsner and do that one, we're also focusing on our community health. Several people have mentioned it. Dr. Smith mentioned, Christina's mentioned, it's going to come after me. We need to focus and be paid for equity. What are we doing in the community? What are we doing in our neighborhoods? What are we doing in our churches? How are we changing health in our community? And we're going to need some investments. Financial constraints are difficult. I am concerned about the future. And Texas has just lost 2 of their strongest independent hospitals that are rural in the last few months, and it's going to continue to happen. So we have to continue to work with Duke and opportunities like this to challenge the way we're paid and come up with more common sense methods of payments. And I won't get on soapbox.
Thank you, Terry. And there's, again, a couple of things there that I would like to circle back to, including some of the efforts that you and others, we've seen this through Jana's efforts and Christina's efforts on working through clinically integrated networks or ACOs or other structures to leverage negotiating power with plans and other partners. And you highlight something that I think is a sort of a common denominator across what we've heard from folks in the field, which is the need to make payment models more simple, but also enable flexibility and accountability. So I think that ties in nicely to some of where our thinking is at in terms of how to improve care and payment transformation. But Jan, I want to quickly turn to you. I know that Christina talked about some of the elements of payment reform that could help health centers, but curious if there's anything else there that you want to add on to or from your experience in the field.
I think the theme of the day is you've seen one safety net provider, you've seen one safety net provider. We're in all different places. And I'd say the same thing about state environments. I think Terry touched on that as well. Safety net providers in Texas have different challenges than maybe safety net providers in California. All very relevant, all very real. But being in a state like Texas, where we do have such a very large uninsured population, we have a tremendous amount of poverty. We have really significant health disparities in our population. So going back to your original question about, what does a successful value-based payment transformation look like from a health center perspective in Texas? It means we actually have health equity. We have access to care and high quality care available to all of our people in this state. And we don't have that right now. And it was really interesting as we started working on value-based care payment models and trying to get the health centers organized in Texas. Initially, everyone was very skeptical because they were like, why would you want to do value-based care in a state like Texas? I would argue that we have to do value-based care in Texas to continue to be financially stable as a safety net. And our safety net in Texas basically are the FQHCs in rural hospitals and emergency rooms. And as Terry said, a lot of our hospitals are closing down in more frontier and rural areas. So we really need to engage this to support our population, but also support our financial bottom line. I think one of the challenges for us is that value-based care and payment are by and large driven by managed care organizations in Texas, but I think we use that to our advantage in working with the state to make sure that the state, as they're procuring contracts, are really incentivizing participation, collaboration, coordination with safety net providers, move away from some of those one-size-fits-all types of value-based pay models that a lot of our national MCOs like to utilize across the country, and I understand why that's efficient for them, but it doesn't always work for a safety net, certainly the health center care model or our patient population in Medicaid. And so I think there needs to be there's some opportunities for the state to really influence that through our MCOs. I agree with Terry that, we're stronger together. And so the health centers have really been able to come together as a group to leverage learning. Our centers are in all different places, but we have some very high-performing centers that are ready to go in risk-based contracting. We have others that are small centers that are not ready to go, but need that extra support and that infrastructure development. I do think in Texas, because we have not expanded Medicaid, our operating budgets are not as healthy as maybe some health centers in other states or other safety net providers. And so that infrastructure development piece is one of the main reasons we've come together as a health center controlled network to help build out that data analytics and aggregation piece that is so vital for any provider to be successful in value-based care. And so we're working together to be able to do that. Also come together to be able to leverage and maximize other resources that are needed, like care coordination, access to specialty care. And Terry mentioned this, being able to come together as a group to negotiate with the payer. A lot of times we have so many small health centers, they don't have the resources to be able to hire a top negotiator to go work with Blue Cross Blue Shield or United Health Plan. They might not even have enough patients to qualify to participate in a value-based care arrangement. And so if we come together as a group through a clinically integrated network, which we're in the process of forming, we'll be able to aggregate our patients to be able to have even our smaller health centers have the opportunity to participate, probably initially at a very low value-based care arrangement, But ultimately, our goal is to get all of our health centers positioned where they could successfully participate in a risk-based system of care. But once again, I think our financial stability really rests on our ability to be successful in this endeavor. And quite frankly, our patients in the state deserve the very best care we can offer them. And so I'm always about, let's also come together and figure out how we can improve quality, how we can improve the patient experience, how we can better support our workforce. Workforce is an issue that people haven't talked about, but it's a huge challenge. And value-based care is also a really important tool in the toolbox to be able to really fully leverage the workforce that we do have. So those are some of the challenges that we're facing here in the state.
That's great, thanks. And again, if we have time, I know that we're running up close to the end of the panel already, but if we have time, I would like to circle back to the issues and opportunities for working with managed care plans. But quickly, I want to turn to Elaine. Echoing what we've heard from other panelists, you see one health center, you see one hospital, you see one provider, you've just seen one. So given sort of the unique operating environment that MLK finds itself in South LA, what, from your perspective, do you think could be helpful in terms of successful payment transformation, or what has not worked from your experience, given some of the value-based care efforts within California?
Well, first, I want to give a nod to my fellow panelists. What a great panel you've put together. I'd love to meet the other executives on the panel. Terry, it sounds like you and I have a lot of the same challenges, so would really love to meet you at some point. So I run a small community hospital with a CMS 5-star rating that serves a large Medicaid population in South LA. We also operate a nonprofit multi-specialty medical group that provides integrated behavioral health and population health programs that include food, transportation, housing supports, and street medicine. We started our medical group with private philanthropic dollars because there were no public dollars available, and we sustain it with contributions from the hospital. We do that because we operate in a state where the Medicaid program exists through an existing managed care infrastructure that filters payments through multiple layers of profit-seeking organizations that frankly are doing a poor job of providing equitable care to underserved communities. And in fact, mostly what they do is provide a series of barriers to quality and access that we have to get around. Hospitals receive reasonable supplemental payments so they don't have to exist on inadequate Medicaid payments, but outpatient community providers don't. So in our community, we have a 1,500 provider deficit. We're lacking 1,500 physicians, and the average community has 10 times as many doctors. Our emergency department is the de facto medical home for people in our community who need care. The largest expense for providing a community-based delivery system for us is to recruit and retain providers. Doctors cost more than doulas. We have patients coming into our emergency department who've had no prenatal care, but now under CalAIM, they can get a doula. We need adequate funding for community-based care. That's our number one need. Secondly, we need pathways for mission-driven organizations to participate in accountable care that doesn't require being dragged through all of the layers of a dysfunctional managed care system. And I would agree completely with Mark, one size does not fit all. Most providers in our community are not FQHCs. We need flexible governance. I don't understand why the government should impose governance requirements on providers that they don't impose on other managed care organizations. So we need flexibility there. One of the reasons that we're so successful is we have an expert board of directors. I agree that we also need upfront investments. We're in the process of creating our own managed care network so that we can contract directly with payers, but we do need investment to build the managed care infrastructure, to create a network of providers, to create a management services organization that can competently carry out the administrative functions, to have the IT infrastructure that's needed. And in the absence of other sources of funding, we're left seeking private philanthropic funding. We've been good at raising private philanthropic dollars, but it doesn't seem like that's the best way to transform an entire delivery system. I'll stop there. And because largely, I think that the issues were identified by my co-panelists, and I largely agree with what they've already said.
That was wonderful. And I think, again, I wish we had 2 hours or more to dive into these issues further. I'm going to extend this session maybe 5 to 10 more minutes, just so we can ask at least one more question. I'm trying to pull or thread the needle across some of the different comments and remarks that you all said. I think there's maybe one or two issues that I'd like you all to touch upon in sort of closing remarks. And that is sort of related. What do you see as effective policies from either the federal or state government that can help sort of provide that pathway from where you sit? And then if you have the opportunity to intermix this within your answer, we've seen, and you all have noted, that there are these emerging intermediary organizations, whether they're third-party enablers or others. And to Elaine's point, sometimes these can be helpful, sometimes they cannot. And so where do you see, what role should they play, and what guardrails or protections or defined parameters should there be to ensure that you all can continue to deliver the care that is needed in your communities? And thank you all. I guess I should call someone first. Christina, I might turn to you first. And I think with 10 minutes, we might ask maybe 2 minutes per person.
Good, because they're actually jackhammering right outside my window, but I just watched him put it down, so I'll speak fast. So specifically, we think that to solve some of the impediments discussed by all of the panelists, that there is a really important role for CMS to play. A couple of concrete examples. One, to come up with specific model arrangements, could be an 1115, could be a state plan amendment, would be 2 examples of instruments that the federal government has to say, hey, state, this is the way that we would like you to do business. These are the infrastructure dollars. This is what we think infrastructure dollars should be spent on. And this is who we think should get the infrastructure dollars. CMS also has authority under the Medicaid program. So the vast majority of states in the country have MCO programs, and it's let 1,000 flowers bloom, and it doesn't have to be that way. CMS could coalesce on the direction that they want to give state government that must be incorporated into the MCO program. Again, a couple of examples. One would be the idea of passing through risk reserve. The other would be rules and regulations around how benchmarks are set and how social determinant of health funding is set.
That was great and pithy. Thank you for that. Maybe Jan, I'll turn to you next.
I love that too, Christina. I've got some tears in my eyes right now. Those are all excellent recommendations. I would, obviously the infrastructure piece is absolutely critical, I think, for all of us. I keep hearing that as a theme. So all the things that Christina said would be incredibly helpful. I would, one of the solutions that a lot of providers are looking at, maybe payers as well, is looking at those third-party intermediaries that you were talking about, Jonathan. And I think that they can be helpful in helping develop infrastructure. My concern is that typically these intermediaries in their business model, they own the contract with the payer. They often own the infrastructure. They basically loan it to the safety net provider. And if the goal is to expedite participation in value-based pay, that's a great strategy. But if the goal is to actually financially stabilize and help a safety net provider grow, provide additional care, and enhance their quality, they need to be able to keep that piece of pie in case that third-party intermediary decides, I'm not making enough money right now, I'm going to take all my infrastructure and go home. It basically leaves that safety net provider where they started. So I think it can be an effective partnership as long as the safety net provider does control the contract with the payers and has the ability to really build out that infrastructure that's necessary for them to be successful in a value-based care arrangement and to continue to invest in their communities to improve health equity and access to care. So that's my 2 cents on the intermediaries.
That's excellent, thanks. And then Elaine, I might turn to you again, sort of what more could state and federal policymakers do to help your work, and if you have further thoughts on some of the remarks that you provided on the role of intermediaries.
Well, I come from a state where the Medicaid program covers a large population and provides a wide array of services, but the rates that are paid to providers are extremely low. So as someone who runs a health system, I always say I get paid adequately to amputate a diabetic limb, but I don't get paid adequately to provide community-based care. I would like to encourage CMS to do more of what Medicaid recently did in approving an element of California's 1115 waiver, and that is require that the state raise provider payments for community-based care and move toward equity with Medicare. There's no reason that we should be providing lower payments to safety net providers who take care of our Black and brown communities than Medicare. So I'd like to see more of that, leveraging the authority that CMS has already to require states to raise Medicaid payment rates for community-based care. We can't do accountable care without that outpatient component being sustainably funded.
That's great. And hopefully we can tee up some of those thoughts or reactions during the next panel. And then in closing, Terry, I'll give you the floor for final remarks and thoughts and anything that you think is relevant for the question that I asked.
Well, first of all, I look forward to meeting Dr. Batchelor. I'm excited about the things she said. And I want to, she's California in Los Angeles, and we're rural. But some of the things that she's saying is spot on. I would say if you said, Terry, you got the magic wand and can fix value-based for rural, funding public health, like Dr. Batchelor said, that's what we need. There's 35 counties in Northeast Texas. 29 do not have a health department for those counties. 9 of them have a health department in there. The other 26 counties have to fend for ourselves. We work with the region, and the state does the best they can. I cannot fault the state of trying, but at the end of the day, our rural health system is the public health department from our county and the 4 surroundings. During COVID, we had the largest COVID per 100,000 in Northeast Texas, immense population of COVID. We had the lowest mortality rate. And we had the lowest mortality rate better than the larger health systems because we made decisions locally, but we were the public health. Dr. Batchelor is spot on. Value-based purchasing for community-based medicine, community-based care, that public health, that's where if we move that focus to, we're going to be able to do some great things from our community. The other one to include in there is whatever we determine, we're going to have to set floors for rural across the United States. Every state's different, but you're going to have to set floors when you talk about these the DSRIP programs, 1115 waiver programs. And DSRIP rule was protected, and we were able to use the money. That has to be set in stone that from a contracting standpoint, the state and CMS are going to have to get involved to protect rules and said there's going to be floors for rural communities. Now, I'm not saying rules shouldn't be held accountable, and we should. Calculate what the cost should be, and it's up to me and my board to make sure we hit those numbers. But give that control locally. We know what's best for our community. Hold us accountable for taking care of our community. But numbers, let's focus the emphasis on outcomes, and outcomes based on communities of color, gender, rural, uninsured, not just one simple outcome, but let's get into the outcomes by segments. And I would love to be challenged. I'd much rather be up all night worried about how we're going to do community medicine than worried about how I'm going to keep my doors open for the next 12 months and pay my bills. Thank you again
Amen,
for the opportunity. Thanks, Doc. I appreciate it, Doc. Look forward to meeting you.
Me too.
Thank you, Terry, and I appreciate the Hawaiian shirt during summer, or during winter rather. It makes me want to move back to Texas. In closing, I'm going to channel something that Patty noted in the chat, which is that the role of integrated comprehensive care in supporting providers of care to vulnerable patients deserves emphasis. And so if we can leverage value-based payment models or other tools to try and drive that comprehensive care and integration and coordination, and I see a number of other remarks effectively noting that safety net providers, while they are unique, have more in common than they are different. So if we can find ways for providers to work together and identify those commonalities, I think that can really do a lot to try and improve care for some of the millions of Americans that get care from FQHCs, urban hospitals, rural hospitals, and so forth. So with that, I want to thank you all for providing remarks. This was a wonderful discussion. Again, I wish we had more time to chat and go into further detail, but I will hand it over to Mark, who will now turn to the policy panel. Thank you all.
Great. Thanks, Jonathan. And thanks to all of our panelists for that excellent discussion and all the bonding that went on in the last session. Boy, this is challenging work, but it's great to see, despite the diversity across the country, some of the common approaches that are emerging to address these challenges of limited funding and making the transition to more person-focused, coordinated care. In this panel, we're going to switch to hearing from a number of federal and state policymaker leaders and experts on how policies are supporting these efforts. Remember, safety net care, financing, and authorities are complex at the federal and state level, coming from multiple different sources. So you hear about some innovative ideas for putting those different programs together and driving and supporting the kinds of reforms that you heard about in the last panel. And maybe we'll come back to some of the suggestions that those panelists had as well. I'd like to quickly introduce our panelists. Their bios deserve a lot more time than I'm going to give them. First, Carol Johnson, Administrator of the Health Resources and Services Administration. Among other things, she previously served as Commissioner of the New Jersey Department of Health Services, where she extended Medicaid coverage and benefits to improve care coordination and behavioral and mental health. Kelly Cronin is the Deputy Administrator of the Innovation and Partnership Center of the HHS Administration for Community Living. Her current work focuses on older adults and people with disabilities, and particularly she directs efforts around community care hubs, these networks of community-based organizations, social service organizations, connected to healthcare organizations to work together to coordinate resources and supports for addressing social health-related social drivers of poor outcomes. Next, Darren Gordon. He's founding partner of Sphere Healthcare Strategies and former director of TennCare. He's nationally recognized for his work on Medicaid innovations, including advancing accountable managed care in Tennessee's Medicaid program. Next, Tequila Terry. Tequila is Group Director of State Innovation and Prevention and Population Health at the CMS Innovation Center, which includes models that span across Medicare and Medicaid to advance health equity, preventative and behavioral health, and social determinants of health, as well as supporting transformation in the safety net. And last but definitely not least, Ellen Marie Whalen. Ellen Marie is Chief Population Health Officer at the CMS Center for Medicaid and CHIP Services, a Senior Advisor for the Center for Medicare and Medicaid Innovation as well, where she has tremendous experience in helping states develop and implement value-based approaches to payment and care reform, including alternative payment models that help address social drivers of health and health equity. So thank you all for joining. We're starting a little bit late. We may run a few minutes late, but we're definitely going to end before 12 is scheduled, but I'm hoping to get in a lot of comments from all of you from this great group. And let me start with Carol Johnson. Carol, we've seen a number of areas where HRSA and other federal agencies come together to try to take steps to streamline and align their programs around whole person care goals and the safety net. Can you maybe talk about some of the key actions that you see underway at HRSA, maybe further steps to support federally qualified health centers, community health centers, and other safety net providers that you fund, and where you see these efforts going in the near future in light of what we've been talking about today.
Thanks so much, Mark. Thanks for the invitation to be here and really the robust conversation that you all been leading on this really important topic. It's so great to be with my federal colleagues here. You mentioned that I had previously served in New Jersey. In New Jersey, we thought a lot about how to link some of our various programs for my colleagues here, how to use our Medicaid program and our Older Americans Act dollars and our workforce dollars to really kind of drive improvements. And that is in some ways what you're the frame that you laid out here, which is really, at HRSA, we fund the 1,400 federal health centers across the country that run 15,000 sites. And we work very closely with rural health clinics across the country. We fund all of the Ryan White clinics that provide HIV care. We really have that community footprint and have for years been doing the work around team-based care and building out community health workers and building out ways to better connect the community to the trusted providers in their community. But as many folks on the previous panel noted, the startup costs can be very hard to transition to value-based payment when you're a safety net provider. That can be an impediment. And so our teams have worked closely with CMS, and CMS has been incredibly supportive of really looking at ways to help address those needs, particularly for rural providers, as we all continue to work on the critical issues around ensuring access in rural communities, and thinking about how CMS can help and work with our teams on some of those upfront costs. So we've been able to leverage some of our dollars to do technical assistance and support for providers in this space. We also have been, as you may know, our health center program is very focused on quality improvement and has been doing the data collection for a long time around what it takes to measure quality outcomes. And so I think, in a value-based world, that's a critical building block of what it's going to take to move there. Like, we have to not only have all the sophistication around how we measure and manage risk, but also the measurement side of the equation and what we know about quality and how we do that. And so we've been putting our dollars towards that effort for some time and are continually working to advance our quality metrics so that we can both ensure we have the best possible care for folks, but also think creatively about how we pay so that we can deliver services in the most efficient way.
Well, thanks for those examples, and I especially appreciate your picking up on the themes we heard in the first session around the challenges for making those upfront investments to develop these care capabilities. And I appreciate all of the efforts underway with CMS and some of the other federal agencies around alignment. But the fact of the matter is, Carol, as you know, the programs that you support, other programs elsewhere in HHS, they have different legislative foundations, different authorities. Are there obstacles to doing this kind of coordination? Do you see any, how have you worked around some of these differences in the legislative accountability and the structure of the programs?
Yeah, so I'm going to talk about two buckets. One, I'll talk about sort of the long-term structural issues, but I also want to talk about the moment that we're in. And the moment that we're in as a safety net community is the public health emergency is going to end soon, which means the maintenance of effort requirements around Medicaid are going to end, which means we're going to spend a lot of time trying to ensure that the individuals that we serve are in coverage, whether that's Medicaid coverage or we transition to the marketplace coverage. That's vitally important for the people we serve, but it's also important for the finances of the facilities that we support. And at the same time, the funds that we were able to direct directly to health centers are those ARP, that plus up dollars, those are running out. Right. We are in the year where we're going to have to go back to Congress and get our mandatory funding for health centers renewed, and like everyone else, health centers are facing the workforce challenges on the ground. So like there's the environment we're in right now, which is incredibly important for us to recognize and address. That's the place where we're working hard across this administration to shore up where we are. And then there are the structural issues like you talked about. We live within the bounds of our statutory authority. And it is, you know, while we have some room, we don't have unlimited room to be flexible about when folks come to us with new ideas. So we're continually also talking to our friends and colleagues on the Hills about ways that we can be innovative, particularly when it comes to workforce. You know, we find a lot of workforce training programs, but they're very specific about who's eligible and what that needs to look like and how our dollars are spent. And so we're continuing to really focus on how do we ensure that we're like meeting the moment, and that requires being as flexible as we can within the bounds of our authority.
And I appreciate all the work that you've done, both in New Jersey, as you alluded to, and at HRSA to try to view those workforce development grants and authorities as ways to build out the capabilities of a team-based approach to care that hopefully can extend clinicians, physicians, and provide a more efficient and comprehensive way to deliver the services that are needed in these whole person care models. Maybe we could come back to some of this in a few minutes, but I'd like to turn now to Ellen Marie. Ellen Marie, you've been at the center of a number of efforts coming in from states, innovative ideas from CMCS, and your dual role at CMMI to pursue innovative payment reforms. So we've talked about a lot of these acronyms, state plan amendments, SPAs, which are, I guess, relatively straightforward to implement in your Medicaid programs, recent guidance from CMS that is intended to support these whole person models, like on in lieu of services that can be paid for as a mechanism to avoid costlier medical services, other guidances that you've provided. Where do you see the most important steps at CMCS now that people should be aware of, and maybe what's coming to help states leverage their Medicaid programs to advance these whole person care models? Oh, and I think you're on mute, so.
Double muted there, sorry. Yeah, we're excited about all the work. Can you hear me now?
Yes, just fine.
We're excited. Good. We're excited about all the activities that we're doing. Again, I want to thank you for having us participate. And the last panel was quite a panel to follow. And I'd like to pick up on some of the things since there were lots of discussions about Medicaid. I think what rings so true about what Mark Smith said in the beginning, that as we're looking at value-based care, this is not just finding a new payment model. Fee-for-service isn't working. A new payment model is not necessarily going to fix that. And so we're really looking to better understand what's the care delivery model that we're hoping that states do, and then finding a payment model that supports that new care delivery model. And Mark, as you noted, Medicaid, we think of Medicaid not just as an insurance program, but as a medical assistance program. And the flexibilities, we allow the states to run their own programs. We approve what they can and can't do. In the last administration, we were really excited to produce a letter, state Medicaid director letter, which is the way we put out guidance for state Medicaid agencies on value-based care, on all the different kinds of authorities that states can use to move forward in value-based care. And as you noted, probably the most simple is just an amendment to their state plan, a SPA or a state plan amendment. That's an easy process. It can happen relatively simply without a whole lot of bells and whistles. As you also noted, managed care. I think 2/3 of our Medicaid beneficiaries are in managed care. And so we're looking for ways to maximize what managed care can cover and also allow the flexibilities of what managed care can cover. And then, of course, everyone often talks about the 1115 demonstrations, which is a harder bar to cross. There's requirements like public review and comment, there's budget neutrality. And so we really want to look at everything. And we released that guidance back in September of 2020. And then the sister letter, as I like to call it, in January of 21, because there was so much discussion of how we're going to improve outcomes with payment models, there was a discussion about what is it that we can do in the social determinants of health space. So in January of 21, we released another piece of guidance that said, here are the kinds of tools in your toolkit that you can move forward to cover social determinants of health. Now, with this administration, we've kind of looked at it and gone further. As some folks have noted, equity is it's a really big priority. It's one of the first executive orders that were signed to look at what we're doing through the lens of equity. And so, as you noted, one of the things that we've done is look to see how managed care plans can provide what's called in lieu of services. So allowing managed care plans to cover services that are similar, but not exactly the type of services that were outlined in the state plans. And before, this has been going on since 2016, examples where you could provide chiropractic services, even though physical therapy services may have been outlined in the state plan. Mobile crisis services could be provided, even though only inpatient psych treatment. But with California at the end of 2021, and just more recently in January of this year, we released more guidance that says we're taking a bit of a more preventive look at this and to see what else states managed care plans could be doing in there. And so now we've approved in lieu of services for allowing beneficiaries to remain in their homes, and things such as sobering centers and housing, navigation, and tenancy support services, day habitation programs. And I guess the second is in lieu of services through the managed care plans, but as you also has been mentioned before, health-related social needs. And we've recently approved 4 different states to go a bit further than what we outlined in the social determinants of health guidance. So now we've evaluated what it is we really takes to improve outcomes. And there are lots of housing issues and nutrition support issues, for example, and I can get into some of them later if folks want to get more details. But we approved 4 different states there. And we've also then put together a slide deck as a bit of guidance that we put on our website to outline the new direction of some of the things that we're approving in these 1115 demonstrations. But I'll stop. I want to make sure that we have time for questions and offer it to my colleagues.
That's great. I wonder if just one follow-up question. You outlined as a great tutorial of a whole long list of steps that CMCS has taken in collaboration with other parts of the administration. Is there any particular area, Ellen Marie, that stands out as maybe being underused or not fully developed by many of the states and the kinds of providers that you've heard from today?
Well, one of the things that we're really excited about, I'm excited about, and I think would be helpful for safety net providers is just in January, we reversed our guidance on paying for interprofessional collaboration or e-consults. And so before, unless the patient was directly in the room and one-on-one or on a telehealth with that single provider, that was the only time we would pay for that provider. But now we allow reimbursement if a clinician wants to talk to another clinician, so a specialist, getting another opinion, and that's a reimbursable service. And so I think of FQHCs and other safety nets that oftentimes are in areas without that array of services, specialty supports, and being able now to do that as an e-consultation. I think in rural areas, that's going to be really important. So since that guidance is brand new, and again, we can provide links to all of this, I think that's something that we're really looking forward to having states take up and figure out ways to promote that's a covered service now.
Great. Thanks so much, Ellen Marie. Hopefully I have time to come back to some of this. And, keeping with some of these Medicaid themes, I'd like to turn to Darren next. Darren, you've directed TennCare. You've done a lot of work with other states since that time and federal authorities. You heard from Ellen Marie about the now longer list of opportunities to advance accountable care and value-based care models in Medicaid. Any particular thoughts or opportunities, challenges you'd like to highlight in this space?
Yeah, thank you, Mark. And yeah, I'd have to say the first panel really helped set this discussion up really well. I think a lot of the authorities, and Ellen Marie, talked about all the flexibilities and all the education about the flexibilities that are out there has been great. But then it begs the question, then why aren't we seeing folks move further along in the process? I think there are a couple different issues there. So one is state capacity. What you see more times than not is the states leveraging their health plans and saying, go forth and try to get value-based purchasing to be a certain percentage of your revenue. And that is primarily because, they're leveraging the capabilities and the capacity at the health plans because they don't have the internal resources to do some of these activities. So that's one thing to keep in mind. I think the other part of it is, in order to do this and do this well, in my opinion, from failed experiments in trying to do it, and then some that were maybe more successful, in order to get good, sufficient buy-in and to understand, meet some of these providers where they are. We heard the discussions, from Terry and others about, the diversity of providers, even within a state or delivery systems within a state. I always bring up Johnson City and Northeast Tennessee is closer to Canada than it is Memphis, and the needs within each area and the delivery system is very, very different. And so how do you pull together the different folks from these different areas of your state and help understand where they are so that you can design a program that meets them where they are, at least doesn't, overburden them or create hurdles from them achieving it? I think that's an essential part of moving things forward. And I will say the way that actually happened for us was through funding, through CMMI, that actually allowed us to do those and have them moderated and be very methodical in the way we're approaching it, so that our model was well informed. So I'd say capacity is an issue. There's different ways that states can leverage that, but the other part of it is I do think some additional support and helping them hear first. What is it? Ready, shoot, aim. You don't want to do that. I mean that has consequences. So helping states spend some time on the front end and trying to structure something that is flexible, but at the same time consistent.
So let me follow up on a couple of points there, hopefully fairly quickly, as I think these are important. You highlighted that many states are trying to do this, but it is challenging and states have quite limited resources too. So maybe a couple of points there. How could you mentioned, I think you were referring to the state innovation model grants before that helped Tennessee, and I'd say a number of other states launch some of these efforts. That program, I think, is defunct now, but people have talked about bringing it back. Maybe some of the concern, as there has been around some of the CMMI models as well, are they linked closely enough to a clear path to transformation or clear impact? If you were going to bring it back and try to be conscious of some of the concerns about, were we really getting progress, what might be done differently at CMMI to make that as impactful as possible? Yeah, I mean, that's a very fair question. And we're in a different spot than we were, over a decade ago, whenever, that first came around. I think to some degree, and this is, Mark, you've heard me say this on multiple occasions, and I think, I'm going to keep saying it until I feel like we've kind of solved this problem. I think having those discussions now is a little bit different than where it was 10 years ago, and that you're not saying, where should I start thinking about going? Because there's already different programs launched in all these different states. But I think we could use that funding and should use that funding to start gleaning from different providers about their experiences with the different models. What's causing them to not engage in some of those models? What are some of the hurdles that they see out there? But also at the same time, so you have what are the barriers, but also what feedback loop do we have about some of the interesting things that some of the providers are doing that are really having true meaningful impact? And I feel, we're going to have this opportunity is going to be lost if we launch value-based purchasing models and we say at the highest level, we see some improvement in outcomes. And I think we're going to make all sorts of inferences from that. Yet there's going to be so many different approaches that providers took to have impact on that. And what can we learn from that? And I think having some of that funding would be helpful so we can spread best practices across the network. And, for those providers that are those early innovators that are leaning in to value-based purchasing, and maybe help encourage those that are somewhat skeptical to say, hey, there's a path here. Yeah, and I mean, it does sound like, maybe this is something we would like to follow up on, and we appreciate your help with it. But next generation investment program that might be a bit more clear about what, each state and local providers are different. But as we've heard, there's some common themes here about the need to build a data infrastructure, about maybe getting the more consistency on clear measures of improving population outcomes, of dealing with risk reserves, et cetera. So there is maybe a clearer path forward rather than, simply 1,000 flowers blooming. And then just one more question on this. You heard from some of the earlier panel, I'm paraphrasing a little bit, saying that, well, there is some guidance out there, but maybe CMS could provide a bit more direction, at least at state options. So maybe setting out, instead of states allocating a certain percentage of managed care contracts into alternative payment models overall, maybe being a bit more specific about ways in which states could align performance measures in those models, or include some funding for provider reserves to take on some of the care integration and risk abilities. What do you think of steps like that? Is there more that CMS could be doing?
I think it's helpful. I think it's obviously a balancing act, right? You don't want to inhibit some of that creativity that's occurring in the system. But at the same time, as I venture down the path of asking the plans to go forth and obtain different levels of their revenue and value-based purchasing, it created a lot of friction in the system, obviously, because they were approaching providers with very different models, very different measures, not particularly helpful. So I do think there is the ability to say, here are some things that we know that work, that are essential key ingredients, for setting people up for success, but still allowing some of that flexibility, outside of, or within those parameters. So I think we took that approach, again, after not getting it right. So I do think there's more opportunity, because here we are almost 10 years later. There's a lot to have been learned. So giving some uniformity, and particularly in quality measures. I mean, we heard that consistently, still hear that today. But I think there are other areas that CMS can say, here's some lessons learned, because I don't know of anybody that's venturing, down this road that isn't wanting to see, the overall system improve, to see outcomes improve, and to see providers to feel that they have more flexibility to do the things they know that need to happen to make their patients healthier. So, having a framework that says, we've learned a lot, here are some things that we think are essential ingredients, but making sure that we don't go so far to say that we've answered all the questions, because I don't think we have.
Great. Thanks, Darren. And speaking of some of the things that we've learned in this past decade around implementing these innovative models and what CMMI and CMS have done to support it, Tequila, I'd like to turn to you now. There's a lot going on at CMMI that, I'm going to oversimplify this a bit, but it's sort of not looking at individual models in isolation, but really thinking about how they can fit together to deal with some of the challenges that you've heard about today, building out stronger accountable primary care, building out that kind of infrastructure to connect different types of providers for more integrated services. Can you talk a little bit about your sense of some of the really interesting things going on now at CMMI and helping especially safety net providers deliver coordinated longitudinal care, plus anything you'd like to react to and some of the comments you've heard so far?
Yeah, well, first, let me just say thank you for having me. This has been an amazing conversation, and there are so many places where I've wanted to jump in. So thank you for the opportunity to share. So I'm just going to start with a little bit of background. I think most folks know that in 2021, the Innovation Center released our strategy refresh white paper. And that paper really laid out a foundation and very clearly articulated our commitment to increasing the number of patients from historically underserved populations and to include more safety net providers in our models. And so at the outset, I just want to say I'm here today to reassure everyone that this commitment still stands. We still believe that is a critical step for us to move forward as we think about our vision for the next 10 years. And so our work continues to be informed by sort of this goal of getting more safety net providers in our models. And then as we think about, how to do that, we have taken some very specific steps over the last year, really to get more insight and hear directly from the experts, people around the country who are currently providing care in safety net provider organizations. From the beginning of this year till about middle of the year, or I should say in 2022, we did a number of in-depth one-on-one stakeholder interviews with safety net providers around the country. And the goal was to help us better understand, what are their perceptions, their experiences, and the reasons providers who are serving so many of the underserved communities around the country today are not applying or actively participating in the CMS Innovation Center models. And really that was the first step, was just talking to folks to get better intel. We also conducted internal analysis on our model applications over the past decade, thinking about, why people opted out, why FQHCs, rural health clinics, community-based nonprofits, what their experience was, what they articulated in the application processes. And what we heard was a number of things. One, there's, a set of responses that told us that, awareness of models and CMMI opportunities can really vary greatly across safety net provider organizations. So there's a clear opportunity to do a better job communicating and making sure that we are directly engaging with safety net provider organizations. We also heard that there is a great deal of variance around the level of staffing and health IT resources and other resources across safety net providers, which can make it difficult to apply and implement our models. It creates a heavy lift when you don't have those resources to do even all of the upfront work just to fill out the application. We also heard things like safety net providers need technical assistance. They need specific engagement and resources in the form of funding to be able to be successful in our models. And so as we started thinking about what we were hearing through those in-depth interviews, through the analysis of our model application requirements, those themes started to emerge. And as we move forward, we're using that information really to build upon design elements for the future models that we are thinking about. We know that there are opportunities to consider care delivery redesign changes and recognize the unique structures that FQHCs and rural clinics and other safety net providers have, and how that needs to be accounted for in the design of models. We also understand that payment structure and redesign is really important. And so building upon the way that we design alternative payment models, recognizing the unique finance approaches that safety net providers often have. And then thinking about performance measurement in particular as an opportunity to recognize, again, sort of the unique nature of how safety net providers deliver care, and that we may need to think about approaches to performance measure that tailor things like risk adjustment strategies and differences that account for safety net provider performance. And so we actually, Mark, this should sound familiar because we really thought about sort of opportunities based on the framework that the LAN Health Equity Advisory Team put together, because we thought that framework made a lot of sense to think about how do we integrate and introduce alternative payment model structures into safety net providers. So that theme of thinking about care delivery redesign, payment incentives and structures and performance measures really is guiding our thinking as we move forward.
Great. Thank you for that very concise but very comprehensive overview of where we've been and where we're headed with all the efforts at CMI and how it fits in with the broader themes that we've talked about. Boy, it does seem like maybe a next round that helps with further with those upfront investments, that maybe helps on performance measures and accountability, getting that right, be both timely and helpful. Kelly, I'd like to turn to you. I particularly wanted to highlight, maybe we can put it in the chat, a recent Health Affairs Forefront article that you contributed to, reflecting your leadership with other HHS agencies to support community care hubs, which is really it's more than just connections. It was really developing a increasingly sophisticated infrastructure for bringing together safety net providers, other providers that are supporting especially underserved populations, people with health-related social needs, and enabling this kind of more coordinated healthcare social service delivery with community-based organizations and healthcare organizations in the community working more closely together. Support that many healthcare providers, particularly safety net organizations, can really use. What's your experience with that so far, and any thoughts about where those efforts can go next to support the goals we've been discussing today? I should say, feel free to go over a little bit past 11:45. We are going to end before 12. You all have much more interesting things to say than I do, and wrap up comments, but really appreciate the perspectives. Thanks, Kelly.
Yeah, thank you for having me. And I think in the context of, payment reform that's really addressing innovative ways to address holistic needs of complex populations, or the populations that safety net providers are serving, the community care hubs is, an approach that we've seen evolve over many years now that allows really more of a community-wide orientation to trying to address health-related social needs or social drivers of health, but at an individual level. And I think what we've seen, probably a lot of us over in our experience, is typically social services is fairly siloed in the way it's delivered, not really well integrated with the healthcare experience. And we've had a lot of efforts underway that a number of federal programs and philanthropy have supported to try to sort of create the connective tissue between social services and community care and healthcare, to make sure that there can be sort of some functional operating infrastructure, so that there could be more of a seamless experience in not only addressing healthcare needs, but also being able to screen and be aware of somebody's holistic needs, and then be able to act on them. So if they're food insecure, get them the food they need, the counseling they need, the education they need. If they're housing unstable, get them their services. So that connective tissue is really what we've been calling community care hubs, which in many places across the country have been larger community-based organizations that have some administrative capability to step up and do the braiding of the lot of different federal, state, local funding that comes to bear in trying to finance these services. So it's HUD funding, it's USDA funding, transportation funding, a lot of different HHS funding that can be meeting the needs from a nutrition, transportation, housing perspective. So really having the capability to not only be recipients of that funding, but to be able to know where does the eligibility rules allow you to braid all those dollars, including contracts from Medicaid managed care organizations, and increasingly through in lieu of services as that takes shape and gets a hold in the market, or with the Medicare Advantage program doing supplemental benefits, or with ACO arrangements, who, for ACOs that are going to be taking an approach to addressing not only screening for, but they want to address and act on health-related social needs. So this community care hub really is a community-focused entity we've seen evolve in many places across the country that have the braiding expertise. They have contracting competencies. They can, be HIPAA compliant as a business associate, receive PHI, be the recipients of a lot of different sources of referrals from many different providers, including Safety Net. So I think we've seen some FQHCs be very competent on their own in their community partnerships because they're so in touch with the communities and the people they serve and who can help them outside of their four walls. But this is complementary to any existing CBO partnerships that might already be in place, and really trying to think through how do we start to replicate and scale this kind of infrastructure. So it's not just available where the most sophisticated CBOs are and health systems that are really going in this direction of really addressing and investing in health-related social needs, but that we can really start to see become more of a norm where most communities are going to have this capability. So we have been working with CDC and CMS and many of our HUD, FTA, USDA, really trying to think about what is sort of the whole of government approach to supporting this. We have funding that we're going to be issuing soon with CDC that will support some of the startup funds for community health, community care hubs. But we've also, for example, most recently worked with the Center for Medicare to point to the alignment and the opportunities with the Medicare Shared Savings Program. And this year, the opportunity for new ACOs to apply for MSSP to be eligible for advanced payment incentives, and the opportunities for them to use those advanced payment incentives, particularly where there's beneficiaries that are in areas of deprivation or that are eligible for low-income subsidies. They can use that funding to partner with CBOs or community care hubs, and they can be then the orchestrators and the organizers of the social care. So I think getting to Carol's points about there's so much pressure on providers now, safety net providers in particular, and we can't expect primary care to take on all of the burdens of the populations they're serving at a time where they're strained and their financing's uncertain. So this is really, in some ways, a recognition of we need to have that complementary community infrastructure that can be the support and true partner to healthcare to take care of the social care, but in coordination and true partnership. So it's an equal approach to this, but in a way that's sustainable. So we can have sort of a collective action model supporting many different streams of Medicare, Medicaid financing, social services, and the other federal and state sources. So, we feel really good in that there's so many great working examples of this already happening across the country. So there's something to replicate. And we're now at the stage with our federal partners, and a lot of people doing this work, to be able to replicate with a lot of broader collaboration. I think there's more and more awareness among healthcare leaders on the plan and health system side and FQHC side that we need to do this well. And as there's more and more expectations coming out through CMS to screen for health-related social needs, whether it's a part of value-based payment or fee-for-service, we know there's going to be expectations and just increase awareness of everybody's needs. So if we start flooding communities and social services with the expectation that everyone's going to rise to meet these needs, I think we all are aware of the fact that we need to have a better orchestrated sort of collective action model that's really functional on a local level that can start to be responsive to having sustainable community infrastructure.
Great. Thanks so much for that overview, Kelly, and great to hear about the different ways in which this basic framework of community level support and infrastructure creation to coordinate social needs and medical needs is coming together. Different ways around the country, but nice to hear about all the progress. We are now at a point on the agenda where it says, final thoughts, wrap up, whatever from me, but I can't think of a better group to crowdsource the final thoughts to than the 5 people on this panel. So if you don't mind, I'd like to ask you for just maybe a brief final comment, one further issue point that you'd like to make, particularly back to what Carol said towards the beginning of this session around the moment we're living in now. This is a time when many healthcare providers feel stretched, feel like it's too hard just to keep doing what they're doing now with additional costs, labor force issues, reductions in all of those extra pandemic and public health emergency related payments. And yet we're seeing many safety net organizations who are in the toughest spot of all, perhaps, taking these steps to move forward with these reforms. So any final thoughts that you each would like to add about how to, as Carol said, recognizing the moment we're in, but maybe using that moment as an opportunity as well. Carol, let me start with you.
Yeah, thanks again, Mark. Thanks for the convening and the opportunity to have this conversation. What's exciting to me about this is as I sit down with the medical residents we're funding and the next generation of the health workforce here that we're trying to build, what I hear from them is we want to be in primary care, but it's hard, right? It's hard to make the choice to be in primary care when that's a 24/7 job and I could go be a hospitalist and I could have a 12 hours, 3 days a week, and that would be my job. So how do we relieve sort of the burdens and stresses and strains? And some of that is value-based purchasing can create that real opportunity to build out the workforce in a way that maximizes everybody at their scope and really ensures that we're doing that. Now, to Darren's point and to Keela's point, like you have to, as someone who ran the programs at the state and now funds the safety net, like capacity, like in order for people to get to the table, to Keela's setting, they need our grant dollars. They need to be able to depend on those resources to build some of that capacity, and the Innovation Center as well. Really, when it comes to, we're investing in the IT infrastructure, we're investing in the quality improvement and like, but the other side of that, the thing that I just want to leave folks with is, I'm then really also invested in the risk equation because, in lots of communities where there's a competitive marketplace for the health workforce or for healthcare delivery, people can take on risk in different ways and the outcomes may not be as disruptive to the community. In the safety net world, bearing risk, and if that doesn't work out well for a provider, it means a great deal to that community. And so thinking about how we help people at what is a really complicated part of this equation is going to be an important part of this work going forward.
Great, thank you. Ellen Marie?
Thanks, Mark. I think that this is a moment, and we at CMS are now Medicaid, of course, is looking with the end of the public health emergency that we have now 91 million Americans on Medicaid, and many of them will not still be on Medicaid after the redeterminations that are occurring. Some that are eligible will lose it. So that, at this point, really is our priority. That said, with equity being a priority, we are very committed to helping states that want to move forward, who have that capacity now. We realize not everybody does, to move forward in a space where they can look at the policies they have in place, look to improve equity, look to enhance their value-based purchasing, look to address social determinants. We are reevaluating many of our policies to look to see how we can pay in certain ways that's going to promote that. So I would say to those listening, work with your states. We are there. We're willing to help. We work really closely with the Innovation Center to make sure that the policies that the Innovation Center is implementing into their models are consistent, because scale and spread, and we want these things, we want the models at the Innovation Center to be able to be replicated at the conclusion. And so I would say just working with your states, if you've got ideas, this is a time where we're really looking forward to reevaluating and moving to pay for the kinds of things that we really think will affect the outcomes of our beneficiaries.
Thanks so much, Ellen Marie. And Darren?
Yeah, I think there's definitely a lot of different challenges going on that it's dividing everyone's attention, but I do still think that there are opportunities to invest in some of the infrastructure that's going to be necessary for folks to then eventually lean into value-based purchasing in more meaningful ways. Just always like to remind folks, this is a journey. I don't think no model we have out there is exactly right and won't need to be adjusted or tweaked. So it is a process. It's not, and it's a journey. It's not a destination. So I do think the last thing we want to do is wait until everything settles down to try to start taking steps in that direction. So I do think there are some meaningful things we can do now to help set them up for success and on this journey towards value-based purchasing into the future.
Thanks so much, Darren. Tequila?
Yeah, I would echo some of the same sentiments from the CMS Innovations Center standpoint. You know, again, we believe very passionately that we have work to do when it comes to making sure the full diversity of beneficiaries in Medicare and Medicaid is reflected in our models. And so as a result of that belief, we have to have strategies that engage safety net providers. And so I would say that there are going to be a number of opportunities as we move forward to get input from safety net providers, to look at opportunities to address some of those issues that I referred to earlier. And then echoing, you know, Ellen Marie's point, like CMCS, CMMI, we have to join together to really ensure that there is a strategy in place to ensure that Medicaid enrollees benefit from, you know, all of the care transformation and payment reform initiatives that we have underway. And that means we have to be deliberate about getting the providers that those beneficiaries rely upon in our models. And so I think there's just going to be a tremendous opportunity for us to reevaluate and think about the specific support that we can provide to those types of providers to make sure that they are a part of, again, the vision for the next 10 years. And so really look forward to more to come on that in that regard.
Terrific. Me too. And Kelly, you get the next to last word.
Yeah, I would echo a lot of the comments that have already been made, and particularly the, I guess, need to have a lot of ongoing learning in the next couple of years. We have some, I think, unprecedented opportunities through some of the Medicaid waivers and some of the flexibilities that are out there now. We've also had an unprecedented amount of federal collaboration in this space. And how do we work together to meet holistic needs of individuals and really take a person-centered approach, and willing state and community partners. So it's so much of this is learning how is it happening successfully and replicating, but also really getting payers to be more fully on board with how do we get to true multi-payer alignment on some of this, and really start to come through with payment for services that complement within, you know, existing laws, but and regulations, but how do we really get the financing model down?
Thank you. It is a work in progress, but I do want to emphasize, and on a positive note of these challenging times, progress. Thank you to all of our panelists today, to our expert advisory group who has helped move this whole project along, to our team at Duke Margolis, and especially to all of you who are involved in addressing these critical challenges and improving coordinated longitudinal whole person care in the safety net. I also want to thank the Commonwealth Fund and Arnold Ventures for making this collaboration possible. It is a moment of a great challenge in the safety net and for our entire healthcare system, but not only where further progress is needed, but where there are more supports, more strategic ability to bring these different funding streams and resources together, more knowledge of what works that we can build on. So encourage all of you to stay in touch with us. Take a look at that Health Affairs Forefront paper today. More coming on this topic from us. And for right now, I hope you all have a great rest of the day, and thank you for joining us.